Okay, good morning, guys. Or is that good afternoon? Some of you is good night. I know some of you are from Australia, Europe, all over the world. But it's certainly a good morning for me here. Today, I'd like to talk about how to place implant right after uh, extraction of a multi-rooted tooth. But before I do that, I want to stimulate you a little bit. Are you a tooth doctor? Because today's dentistry is too exciting to be just a tooth doctor. And I'd like to show you some of the cases. This phrase, tooth doctor, was the response I got when I was dating my wife. As a dental student, I try to show off that I was a dental student, but her response was, "What? You are a tooth doctor?" So, I knew I didn't want to be just a tooth doctor. So as soon as I graduated, I started incorporating orthodontics and implant dentistry into my practice. And funny thing is, I think, implant was too exciting so that my wife ended up going into dental school 4 years after um, getting married with me. So she's also a dentist now. Uh, I'm sorry? And then one day I hope that my son can also be a good dentist. And he's actually doing a lot of hands-on training on his daughter. Okay, are we having any technical problem? Then let me know. I know I got some of the response here. Can't hear the audio. So if that's the problem, let me know. So typically, as an implant dentist, we tend to be very narrow vision. As you can see in this patient, I think 99% of you will think, well, we need to extract tooth number 330, maybe do some bone graft and an implant to number 19, and do some root canal PFM number 13. So this will be your typical treatment plan, but I want to stimulate you today that instead of just doing standard implant dentistry, I think we can do a better service to the patient if you can actually extract the tooth, and instead of doing an implant for this young lady, we can actually bring the molars forward, because today we have a great device called temporary anchorage device, so you never run out of anchorage. And now, since I brought the second molar forward, uh, third molar, comes up to the second molar side. And I think nothing's better than natural tooth. I mean, implant cannot be better than natural tooth. We're just a human. We can never be better than God. So always consider restoring with natural tooth. Um, how about this case? In this case where number 5 is missing, you would have to do a lot of bone block or GBR to gain the bone, and then afterwards you would have to do free gingival graft, apically repositioning to gain amount of attached gingiva. But after reading Dr. Salama's article when I was a dental student, um, it kind of opened my eyes. Instead of doing a bone block and so on, we can do simple orthodontics to bring the tooth forward, now gaining natural bone. This patient came into my practice. Her chief complaint was fremitus on the anterior tooth and the mobility, and she wanted to close the gap, but it's impossible to close the gap here because her bite is so strong. She has exostosis, maxillary tori, a lot of fracture lines on the incisors, and fremitus on the anterior teeth. So in this scenario, you would have to open up the vertical dimension in order to close the gaps, but opening up vertical dimension in this heavy clencher is very difficult. As you can see in her lateral ceph, her mandibular plane is below the base of skull. That's an indication of brachyfacial, very heavy function patient. So in this type of case, if you extrude the tooth, it will become intruded right away. But by using Botox to inject in the masseter muscle, 30 units each, bilaterally to kill the muscle temporarily, we are now able to extrude the teeth in any way we want to do. So and then with leftover, you could do some side job if you need more money, and you can close the gap now because we increased the vertical dimension. Therefore, you have more room to close the anterior. So if you be open-minded, try to incorporate all the new technology out there, I think the sky is the limit, and that's why I think dentistry is so exciting because I mean there is no limit as to what we can do as a dentist. So don't be just a tooth doctor. Here I had a difficult time placing an implant to number 29 because of limited mesial-distal space. By putting a temporary anchorage device, I was able to distalize the two molars back even without doing any braces on the anterior. So instead of compromising my implant restoration into very skinny tooth, I was able to put regular looking bicuspid tooth. So there is no limit as to what we can do as a dentist, and without doing some sort of orthodontics, I don't think that you can do a perfect implant dentistry. Here, there is a severe extrusion of upper teeth. It's very difficult to place implant on the lower. I mean, you can place them, but it's very difficult to restore. Here, after placing an implant, there is no vertical space to put a crown later. So with the temporary anchorage device, we can intrude the teeth all we want. One implant on the buccal side and one implant on the palatal. I was able to intrude the teeth, create a better environment for your implant prosthesis. If I had not done this, probably I had a problem with the cheek biting, floor of the mouth biting, poor retention of lower implants, and by doing simple orthodontics, I think we can make a much better environment for the patients. So we can change the occlusal plane, we can help the patients a lot better. This patient came in with gummy smile. By putting a temporary anchorage device, you can reduce the amount of gummy smile and gingival display. I have a lot of Korean patients. Asian patients tend to have a lot of class 3. In that case, I will place 2 TADs on lower mandibular and then run class 3 elastic if they are deep bite tendency, and then bring the maxilla forward using that instead of using a reverse headgear. Therefore improving the face and also improving the overjet. So as you can see here, it's just too exciting to be just a tooth doctor because there are so many things we can do here for the patient. Here, patient presented with relatively straight teeth, but patient had an occlusal cant with one mini screw, which is only 1.6 millimeter in diameter. I was able to intrude the whole maxilla. I know that I intruded the whole maxilla because she lost the bracket in tooth number 9. Because she lost the bracket there, I know that tooth did not move, and that mini screw was able to distalize at the same time, intrude the whole maxilla except tooth number 9. Let me show you a more severe case. This patient came in with extrusion of upper dentition, a lot of wear on the anterior. With all the tools that I showed you so far, we are able to fix her bite because right now she has a class 3 bite. She's unable to chew, plus she has some gum recession because of traumatic occlusion, a lot of spaces. And here, there's no doubt we can place implant, but as I mentioned before, you can place implant, but you cannot restore this case because there is no space to put a restoration. And other side, we have a similar situation, collapse of vertical dimension and unfavorable situation. So let's not focus so much on the decay because we're not just a tooth doctor. We're able to do a lot of stuff for the patient. So let's just not focus too much on decay for now. I did some orthodontic workup. I placed some implants to open up the vertical dimension, and I placed implants bilaterally because I wanted to use those as a permanent anchorage, but I placed those implants more distally than I really should. This implant should be 4 millimeter from distal of bicuspid or the canine, but I placed them 8 millimeters distal to the most distal tooth because my plan was to distalize 4 millimeters. And using the temporary anchoring device, I wanted to intrude the upper maxillary teeth. So I waited for leveling and aligning, and now you can see a huge open bite when I try to restore the implant because of extrusion of upper teeth. I was really tempted to extract the upper teeth, but I really believe in temporary anchorage device to do intrusion. As you can see here, in 3 months we were able to close the class 3 open bite and make much more favorable situation. So if I refresh this, she had a collapsed class 3 bite. We opened it up with implant and we closed it with the temporary anchorage device. So as you can see, sky is the limit, and now she can have a beautiful restoration that she wishes with proper function. But it's not just the veneers or restoration that I was proud of. If you look at her face before and after, you can see a tremendous improvement in patient's face. In fact, she's now even wearing makeup, and she has multiple boyfriends. And, she gains self-confidence in herself. She becomes a better person. So I want to tell you guys, hey guys, we're not just a tooth doctor. We are real doctors. We can do a lot of things for the patients. So I wanted to stimulate you a little bit to incorporate implant dentistry and orthodontics into your practice. When I saw this patient with the unilateral extraction case, you can see a severe facial asymmetry in her face, and it kind of broke my heart. So I decided to extract other side because I believe that face comes before bicuspid. I mean, bicuspid is important, but I think face takes priority of bicuspid. So now she can smile, and as you can see, she has much better symmetry because we did bilateral extraction instead of unilateral extraction. So in my practice, we really focus on the face, not so much on the tooth. So when I get a new patient for consultation, we'll look at the face first, especially the profile, and then my trim implant comes to improve the face first, and then we look at the tooth later. So I wanted to stimulate that. As you can see, many patients we can correct, we can improve their facial profile doing non-surgical orthodontics and implant dentistry. I mean, this dentistry is too fun, and I wanted to begin my presentation by telling you guys, don't be a tooth doctor. Let's get a bit bigger picture and treat the face and the oral cavity. So let me go into my real topic, immediate molar implant placement right after extraction. God gave us 32 teeth, and it all comes in different diameter and different length. Now, if you are just using one or two implant size, 4 or 5 millimeter in diameter, I want to ask you, why are you implanting bicuspid implant into every location? Because you really 4 millimeter or even 5 millimeter implant is really for bicuspid. I know posterior maxilla has a really weak bone quality, so I used to think longer the better when I first started doing implant dentistry. But as you can see, this patient has some crestal bone loss, and we thought that's just the normal according to the literature. 1 millimeter bone loss first year is acceptable. So I thought this is just normal, but patient comes back 1 year later with screw loosening. So as a regular dentist, I will adjust the bite, and I will check the occlusion, grind a little bit, retorque the abutment screw, and then guess what? 6 months later, patient comes back, same scenario. I had to adjust the bite again, and then recheck the occlusion. And then 3 months later, patient came back with the broken implant. So I had to remove the implant with the trephine, and I felt really embarrassed. Therefore, instead of doing bone grafting, when I met this implant system called Rescue, because it was really designed to rescue this type of scenario where you have the failed cases, I immediately placed this implant into the socket. But the funny thing is, this implant doesn't get screw loosening anymore. And this implant doesn't get crestal bone loss anymore like I saw before. And I want to talk about those characteristics in this seminar. If you look at this literature, every time you increase the diameter of implant by 1.25 millimeter, you increase the risk, you decrease the risk of fracture by 3 times. And if you have a 6 millimeter implant, you decrease furthermore. So bigger the implant, less likely to get implant fracture. Here, let's compare 4 millimeter implant versus 7 millimeter implant on the posterior. I know 4 millimeter implant, I gotta make narrow occlusal table. So it always looks unnatural. And I'm sorry, I'm getting a whole bunch of messages. Hold on. And the patient's response is, "Doctor, why are you making narrow occlusal table? Why is my tooth half the size? Can I pay you half?" Well, if you're only making half the size, we deserve to get paid only half. Versus on the right side, we have more natural looking size of the restoration. We deserve to get, what we deserve in full amount. Why do I put narrow occlusal table on the 4 millimeter? Because I know there is a lot of bending moment buccolingually if I make a normal size tooth. But how about mesiodistally? Now, 4 millimeter implant, if you look at the x-ray, it looks much, much weaker than 7 millimeter implant, obviously. But even though you have a nice contact, patients will always say, "Doctor, food gets underneath and it drives me nuts when I go to the restaurant." So, why is that happening? It's because of poor emergence profile. You don't have a papilla on the posterior because you're coming from narrow implant into a very big 11 millimeter mesiodistal crown dimension. Versus on the right side, you have much better emergence profile because you have a bigger platform, therefore you have maintained papilla on the posterior. How about screw loosening and crestal bone loss from physiological standpoint instead of biological standpoint? So nowadays I think a lot of literature have a tendency to quote that bigger implant the better. Seating surface of prosthesis will increase. It will double if you increase just up to 5 millimeter, but if you increase to 6 millimeter, it becomes 4 times bigger. Therefore, you have a less bending moment. So if you don't want to have any screw loosening or marginal bone loss, I think it's better for you to put bigger platform, bigger implant. Not only that, your surgery becomes very easy because instead of placing 13 millimeter implant, now you can place 8.5 millimeter implant, and it's very atraumatic surgery for the patient. So I found plenty of literature supporting wide diameter implant, and I really, really strongly recommend you to place wide diameter implant when there is available bone in the posterior region. Now, only problem with the wide diameter implant is that if you are placing 7 millimeter diameter implant, imagine how many drilling you have to do. I mean, this could be a stressful event for a surgeon because you have to go through 7 drilling steps. But instead of doing that, we utilize Trefine, so that instead of using 7 drills, you can finish everything with just 1 drill. Let me show you this case where patient presents with severely worn down dentition, very brachyfacial, heavy muscle function, bruxer, clencher, and all that scary stuff that we can think of. But typically, if this patient does not have endodontic or periodontal lesion, patient will present with very wide bone, buccolingual. In this case, you should be ashamed if you put regular size implant because you will have the same problem I had with the screw loosening, crest bone loss, poor emergence profile, and so on. So here, I want to place wide diameter implant, but this patient, as you can see from occlusal view on the right side, he has ample amount of attached gingiva, and here instead of opening flap, because patient has ample amount of attached gingiva, I will just use trephine. I will go down. Now you can collect this bone with the trephine, and if I'm doing full mouth implant, I could use this autogenous bone on the upper for the sinus graft or any bone graft that you choose. And we insert the implant, and instead of suturing, here I just put healing abutment. Now if you really think about it, how long this type of procedure takes? Number one, you're not opening any flap. Number two, you're not suturing at all. Number three, it's only one drill with the trephine. So this shouldn't take you more than 1 minute. But you have to be careful, because if you do it too fast, it's difficult to collect money from the patient. It's a joke, guys, but because webinar, I cannot see the audience, it's not too fun. Because I don't see the reaction from my attendees. I feel like I'm talking to the wall. Okay, so very stable, and 6 months later we'll restore the case. Now, I always wanted to place implant right after molar extraction, as you can see here, but I met this rescue implant 3 years ago, and before then I did not have the right tool to do this. And biggest implant I found back then was 5.0 implant, and placing that 5.0 implant right onto the furcation is not that easy, but I managed to do it. However, second thing was the gap between the implant and the tooth was so large, that jumping distance is so large that I had to get primary closure. So here, I'm Asian, so I do good sashimi. I did good sashimi to get primary closure, but that was the most dumbest thing I did, because 6 months later, I had to do another sashimi to bring down my mucogingival junction down, because by getting primary closure, I lost my mucogingival junction. So I was thinking, isn't there an easier way to do this? Isn't there a better way to do this for the patient and for me? And that's when I met Megagen implant with this wide diameter implant called rescue implant. Here, right after extraction, you have plenty of bone. So if you tell me your patients don't have bone because you're waiting after they get resorbed. Here, even after 7 millimeter implant, I have a 3 millimeter on the buccal, 5.5 millimeter on the lingual. That's more than enough bone. Instead of doing sashimi to close, I will use 10 millimeter healing abutment to block the socket so that the blood clot does not escape. As long as you maintain the blood clot, you will have bone formation. And then I will restore the case. And this typical case does not take longer than 3 or 4 months. And I think you get a better healing when you have extraction socket. If you think about it, implant 7 by 8.5 or even 7 by 7 is good enough. It's very atraumatic surgery, because it's usually shorter than apex of the root that you extracted, which means if there is a tooth, 7 by 7 implant always fits. Okay? So you never have to worry about nerve or the sinus, because if there is a tooth, there is a room for 7 by 7 millimeter implant. Patient was so happy, he wanted to do upper implants, but I told him, you cannot do upper implants unless you do simple orthodontics. And you know, I always feel that way. Without orthodontics, you cannot do perfect implant unless it's an immediate extraction case. So orthodontic is a very large portion of my practice, and I recommend it for any implant surgeon to learn orthodontics. Now let's look at the surface area. 4x10, which we call it a standard implant, has a 152 millimeter square surface. 5x8.5 has 164. 5x10 has a 198 millimeter square. Now 7x7 implant has a 231 millimeter square. So it has almost 1.5 the surface area of 5x8.5. So you don't need to put anything longer than 7 millimeter when you're using 7 millimeter implant, making the surgery very minimally invasive for your patient. Let me walk you through step by step how to do this implant surgery. As you can see, patient has a fraction line running all the way from distal to the mesial. It's a hopeless tooth, and after doing atraumatic extraction, what is atraumatic extraction mean? That means preservation of buccal plate. As long as you have a good buccal plate, because buccal plate is the weakest bone, you have to do anything it takes to preserve the buccal plate. I will extract the tooth one by one, and then I will use reversed direction with the trephine of my choice at 1000 RPM. You need to do this in reverse so that the trephine does not jump around. Rescue implant comes in several trephine sizes. If your goal is to place 6 millimeter implant, I would recommend you to use 5 millimeter trephine. It's called 4050 trephine, which means 4 millimeter inner diameter and 5 millimeter outer diameter. And then try to place implant 6 millimeter. If you want to place 7 millimeter implant, I recommend you to use 5060, which is the 6 millimeter trephine, and then try to place 7 millimeter implant. Now, that's for upper jaw, very spongeous bone, okay, because they have a tendency to expand and forgive. If it's on the mandibular, you might have to do additional drilling, such as a 5.4 pilot drill after using 5.0 trephine in order to place 6 millimeter implant. And then I like to go 1 millimeter beyond my length from the buccal plate. For example, if I want to place 8.5 millimeter implant, I would like to go 9.5 millimeter. Now, removing this bone is always the difficult part. So I also developed this tool called Trefitone, and it could be purchased through Megagent. By using this Trefitone, you can remove this bone core without damaging or enlarging this socket that you created. After you remove this, you can collect this bone, and after you collect this bone, you want to insert this implant, but you want to leave at least 3 millimeter of buccal bone, buccal space, including the buccal bone, so that you minimize the resorption. And I collect the autogenous bone that I got. If that's not enough, I like to use freeze dry bone, cadaver bone, and then pack it on top of the implant. But be careful, before you pack the bone, you need to put this healing cap so that bone graft does not go inside the implant. Afterwards, the autogenous bone that I got, I will mill it. But it's important to use this type of bone mill with the stopper, because you don't want to pack the bone you don't want to grind the bone too small. You want to kind of, the particle size should be big enough. I think bigger bone particle, the better. Why? Because as you can see on this patient, on the day of a surgery, palatal side, there is more gap between the implant and the bone, palatal bone. But there, I put bigger bone particle, and then on the buccal surface, I put smaller bone particle. And then I used this 10 millimeter healing cap. And then when the patient came back 1 week later, I took it out just to see what's going on, to take a photo. As you can see on the palatal side, epithelium almost grew all the way. It's already healed, which shows that bigger bone particle is favorable to healing. In 2 weeks, it's very similar, buccolingual, but I recommend bigger bone particle because it makes the healing much, much faster.